Good morning. Uh, I'm Dr. Jheelam Biswas from NICS Dhaka. I'm working as the Assistant Registrar of Critical Care Medicine. Today I am talking about the end of life care needs among the patient with incurable disease. First, before going to the burden of the end of life, we need to know what is the end of life. There are different definitions, but widely regarded that it is the last 12 months of the life of a patient with an incurable disease. And usually it is determined by the surprise question that what if will we be surprised if the patient die in the next 12 months. So, during the end of life, patient and their families suffer various burden. It is an iceberg. We can see the symptom burden, high level of physical symptom burden, but below the iceberg there are various unmet needs like a psychosocial and existential burden, and there is other spiritual burden, caregiving burden, etc. And we can see that the burden is much higher in the low income countries like Bangladesh. It was about, according to the Lancet Commission report, it is about 61 million people suffer in that serious health related sufferings, and it is about 6 billion day symptom per day. And this uh, unaddressed burden reduces the quality of life of these patients. So, what are the priorities of the end of life? There are mainly four priorities: pain and symptom relief. It includes both physical and psychological symptoms, meaningful communication about goal setting and the end of life care, family burden, also the place of death, emotional reassurance both to the patient and their families, and spiritual peace. It is the resolving the existential crisis, saying thank you and goodbye. So, what is the end of life care? It is the care for the dying person and their families at the last stage of the disease. What includes the components of end of life care? It is the physical support, which includes the physical symptom and pain and others symptom management. Spiritual support, it is spiritual guidance and comfort to achieve a spiritual peace. And emotional support, both emotional needs of the patient and their families. Also, the all these supports we can achieve the comfort and dignity of the patient. It is the ultimate goal of the end of life care. So, there are many barriers to the end of life care in our country. Mostly in the Asian country and mostly in Bangladesh, the cultural norm discourages the open discussion about death. Also, there is limited awareness, both public and profession. Also, there is some misconception, policy gap. Mostly, it is restricted to Dhaka, the capital city, as well as it is mostly restricted to cancer. And there are regulatory barriers such as opioid availability, also inadequate resources, manpower, both infrastructure and manpower limitations. And the global palliative care assessment, we can see that in the low economic country, about 80% people suffer from serious health related problems such as pain, dyspnea, physical and mental and spiritual sufferings. And it increases about 83% in the last for 31 years. It is about 46% than the high income country to low income country. And the palliative care access in the Bangladesh is, it is the old data, about 6 lakh patient need palliative care, but only 4,000 has access. And end of life care is a part of palliative care, but palliative care is a broad term. So, we are mostly focusing here in the end of life care. What is the domain we will assess for the end of life care needs? It is need, social need, existential need, symptom need, and therapeutic need. So, these 13 needs are assessed in our study. It was a cross-sectional study which was done in the 4 administrative division in the 4 tertiary and secondary healthcare, where palliative care is currently unavailable. Those are Sher-Bangla Medical College Hospital from Borishal Division, Thakurganj General Hospital from Rangpur Division, Khulna Medical College from Khulna Division, and Gopalganj Medical College from Dhaka Division. And our total sample size was 301 patient. We selected adult patient 18 years or older, and those who have one of the 7 serious and complex medical conditions such as end-stage cancer, congestive heart failure, end-stage liver disease, end-stage renal disease, requiring hemodialysis, stroke, dementia, oxygen-dependent pulmonary disease, or COPD. Also, ECOG performance was more than 2. That means patient needs help to do their day-to-day activities. Also, previous to prior unplanned hospital admission for their condition in the last 6 months, and we also assess the end of life, is if the patient in the end of life by the surprise question. And the main criteria of our study was that patient never received any palliative care or palliative care consultation. So we use 3 tools for their assessment. One is NACE 13, which assesses the end of life care need, the SS scale for symptom assessment, and palliative performance scale for their functional assessment. Among 301 patients, they're mostly male predominant, about 56.8% patient are male, and we can see that 17% patient was in the terminal stage, that means PPS level 10 to 20%, disable state was 28.2%, which was PPS level 30 to 40%, and moderate state, those have PPS level more than 50%, those are about half of our study population. And we can see there are 5 diseases we have selected, and most of the patient were in adverse cancer followed by COPD and dementia. And we can see that among our study participants, 301 patients, there is high level of unmet end of care need, that is 87%. And among the domains, the most unmet care needs was assessed in the doctor-patient relationship, goal setting, spiritual needs, and then financial needs, and other is access to care, closeness of family. Those are also high, but these are the mostly documented needs. And when we assess the variable, different socio-demographic variable with the need assess end of care life needs, we can see that patient with longer disease duration, that is 12 months, has higher need than the patient has a higher end of care need that patient with the shorter disease duration. Also, the patient with end-stage liver disease and advanced cancer has higher level of unmet care end of care needs. Also, we can see that from the SS scale, there are 10 symptoms, and we can see the higher the symptom level, the higher the unmet end of care needs. And here is the multiple nominal regression. We can see that in the terminal stage, the highest end of care needs is the physical need, and followed by spiritual caregiving needs, and other needs are higher, but these 3 are mostly statistically significant. And in the disabled state, the needs shifted. Physical needs is still higher but lower than the terminal state, and also there is the sense of purpose and spiritual need. And interestingly, the goal setting need is higher than the disabled state, because in this state, patient needs to determine their goal of treatment and the further end of life care management. So, as per our knowledge, it is the first study to explore systematically the end of life care among the Bangladeshi patient who lack access to palliative care. But we have some limitations. This is a cross-sectional study, so we cannot capture the change overall the period of their disease trajectory. Also, it is the self-reported data by the patient, so there are some recall bias may be added. So in conclusion, we can say that our study reveals that the overwhelming burden of end of care leads in the patients who lacks the access to palliative care. So we can say that we need to urgently access the holistic and culturally sensitive end of care need, end of care, end of life care among our mainstream healthcare services. Thank you.
Thank you, Dr. Biswas, for your nice presentation.